12:15, and we'd like to get started. And first, we're going to open up with a word of prayer. Can you bow your heads in reverence? Father, we thank you for this day. We thank you for an opportunity to come together as colleagues to discuss the business of minimally invasive surgery and the issues that impact our community, our healthcare, and our individual patients. And Father, we pray, God, that you would grant us clarity of thought, precision of expression, and allow us to learn from each other as we embark on this symposium that would enhance what we know to improve the health of those we serve. In Jesus' name, amen. Okay, so I've been charged to give the welcome. And so I'm going to say welcome to this symposium. And I believe that this is the second annual minimally invasive symposium put on by one of our dearest, Dr. Lucas and team, the vascular team. And today is supposed to be a great evening, and it is my great pleasure to welcome all of you. And we are honored to host such a dynamic group of healthcare professionals, innovators, I would say educators and learners who share a common passion for advancing surgical excellence throughout our community in minimally invasive techniques. So over the next few days, this symposium will serve as a collaborative platform to explore the latest in laparoscopic, endovascular, and interventional procedures. There's a vast program from uterine embolization to robotic surgery to endovascular surgery and a wide array of topics that reflect the evolving landscape of minimally invasive care. What makes this symposium especially unique is the hands-on component. And we also believe that learning through doing, we surgeons, we like to see one, teach one, do one. Doing is the most impactful way to master these techniques. So you'll have the opportunity to sharpen your skills, deepen your understanding, and bring back practical knowledge that can enhance both patient outcomes and your everyday clinical practice. Beyond the technical aspects, this event also is about connections. You'll have the chance to network with colleagues, engage with expert proctors, and participate in meaningful discussions about surgical innovation and the mere challenges that we face in our community. Minimally invasive surgery in our community cost, and there's a burden to those that bring it. And these are some conversations that are essential for us to have, not only for our own professional growth, but for the collective impact we can make in improving care. I'd like to recognize some of the people who made this possible. We'll call them our partners in industry, such as Viren Company, Viren USA, Bahamas Medical and Surgical. These are all partners, and also Ports International. Finally, you could also look forward to getting some CMEs. This symposium offers a valuable opportunity to do so while engaging in cutting-edge content and interactive experience. So, I don't really have a whole lot to say, but on behalf of the organizing committee, Dr. Lucas and team, and our industry partners, Department of Surgery, I thank you for being here, and your dedication to learning, collaboration, and excellence is what will make this event a success. So let's make the most of our time together. Let's share let's learn, let's inspire, let's innovate. So welcome again to this symposium, and I hope you enjoy. And may this have a meaningful impact on your career going forward. Thank you. So that brings us back on time. And so we're going to bring Bodhi to introduce our first speaker. Yes. Watch the cards. We don't want anybody falling.
Good afternoon, everyone, and welcome again. Today, I have the pleasure of introducing our first and also the other speakers for this evening's activities. Our first speaker is well known to most of us in the room, if not all of us. And I have journeyed my ongoing medical career with this young man as student colleagues, resident colleagues, and now as general surgeon colleagues. He is a husband and father of two, and a recent graduate of the University of the West Indies Doctor of Medicine and General Surgery program. Since completion of his surgical residency, he fulfills his duties here at the Princess Margaret Hospital as one of our very own senior registrars in general surgery. Importantly to note, prior to completion of his general surgery residency, he underwent an elective rotation in colorectal surgery at the University of Calgary in Alberta, Canada, and they actually liked him so much that I am pleased to announce that he has been accepted as a fellow for the upcoming colorectal surgery fellowship in July 2026. Let's congratulate and welcome Dr. Holly Nixon.
Good afternoon, everyone. Thank you, Dr. Bodhi, for that warm welcome. I sent her my bio last night. I didn't remember telling her all of that stuff. She did her research on me. All right, good afternoon once again. It's a pleasure again to do this talk. Last year was our inaugural start for this workshop that Dr. Lucas and I, particularly Dr. Lucas, who spearheaded this, felt that this is something that we could introduce into the program, and it would help residents along with the seniors in terms of advocating for advancement in minimally invasive surgery and endovascular procedures as well. All right, I have no disclosures. My talk will be basically on advancing minimally invasive surgery at the Princess Margaret Hospital and a young surgeon's perspective. Briefly, I would go over some of the principles of laparoscopic surgery, advantages versus disadvantages, the history of MIS at the Princess Margaret Hospital, looking back at some of the pioneers in the past and what's going on currently and the future outlook. So by definition, minimally invasive surgery essentially is the means of performing major operations through a small incision using miniaturized high-tech image system to minimize the trauma of surgical exposure. In terms of some of the principles that are adhered to when performing minimally invasive surgery, particularly laparoscopic surgery, some of the procedures or techniques that we try to achieve to obtain a safe, minimally invasive procedures. One, maintaining adequate exposure or insufflation to create a space, visualization, assessing for anatomical landmarks, tissue, surgical, and exposing the surgical environment, and also when placing your primary and secondary working ports, adequate placement to avoid any what is quote unquote described as sword fighting, or we try to aim for triangulation when we place in our ports. Adequate retraction and exposure, and performing intracorporeal and extracorporeal anastomosis and hemostasis. Everybody know basically some of the advantages for minimally invasive surgery, which is why it's advocated and it's basically standard of care worldwide. Is they have the added benefit of decreased wound size, better cosmesis, improved visualization, decrease in temperature or body heat loss, reduced wound infection and dehiscence, the bleeding, and also the risk of herniation from larger wound incisions. Less postoperative pain, early ambulation, and getting these patients out of the hospital and quicker to their regular quality of life. And of course, some of the disadvantages, basically, as mentioned by our introducing speaker, there's a lot of volume that is required so that surgeons can be efficient when it comes to minimally invasive surgery. And a lot of time there are some difficulties in obtaining hemostasis that can result in conversion. Retraction of large specimens as well, and loss of tactile feedback. Some of the disadvantages. And of course, there is a learning curve that required expert and training requirement. Now, just to touch on some of the pioneers at the Princess Margaret Hospital in minimally invasive surgery, there are a few first surgeons that I have to mention today. And this slide is courtesy by our very own Dr. Delicia Bodie. So the first laparoscopic cholecystectomy was performed by Dr. Loxley Monroe in 1994. The first laparoscopic colectomy procedure in 2009 was performed by Dr. Wesley Francis. And the first laparoscopic nephrectomy by Dr. Anwala. Single incision cholecystectomy and colectomy was a combined effort by Dr. Wesley Francis and Loxley Monroe that was done in 2016. And the first laparoscopic, this is an honorable mention in terms of prostatectomy. It was not performed at Princess Margaret Hospital, but over at Doctor's Hospital by Dr. Gregory Pinto. And these are some of the pioneers as illustrated in the pic. So currently, at present, minimally invasive surgery is performed here at Princess Margaret Hospital. The majority of our laparoscopic procedures includes laparoscopic cholecystectomies and appendix. It is the standard of care worldwide. The residents are trained as they progress through the DM program. Once they get post DM1, then they embark more on acquiring these skills at the laparoscopic level. In terms of colorectal surgery, the majority of laparoscopic colectomies are performed by Dr. Major and Dr. Francis. They are surgical oncologists. And this is one of the areas that I looked at and said, well, eventually these gentlemen, they would eventually move on. And we need to fill in the gap, or we need to train more surgeons, up-and-coming surgeons in these areas in particular. And most of these procedures are done on an elective basis. What's the future looks like for MIS? One, we try to aim to produce more trained surgeons in MIS. Bariatric surgery is another area that is lacking. Here at PMH, urology, there are endovascular minimally invasive procedures that are happening worldwide. Of course, not offered here at Princess Margaret Hospital. One of our very own resident, Dr. Kelly Johnson, essentially is in the pipeline, and hopefully she can return and introduce some of these minimally invasive procedures. And myself, that is embarking on a colorectal program in the near future. Robotics is just a mention. I don't know if it would ever get in our system, but wishful thinking, but we always have to bear in mind that robotics are something that can possibly happen, probably not in our lifetime, but in the future. Acquiring laparoscopic simulators to train residents, like Dr. Lucas has spearheaded in conjunction with some of our partners, Bahamas Medical and Surgical Supply. We tried to acquire some of the laparoscopic simulators. We're still in the process of finding a venue in terms of the skills labs, and essentially setting up a program where we'll have the residents engage in periodic laparoscopic simulator training. Annual workshop like this is encouraged, just to reiterate and to advocate the need for minimally invasive surgery. And then, of course, international laparoscopic courses in collaboration with our international colleagues and surgeons in the Caribbean. They may be offering courses or may be willing to come into our system and provide some of the skill sets and their expertise as well. So essentially the key for minimally invasive surgery and becoming efficient and adequate in this skill set is volume. Like I said, volume, the equipment we need to acquire, and we need to produce sufficient and adequate residents and surgeons in this area as well. So in conclusion, MIS surgery is the standard of care in the developed countries. At Princess Margaret Hospital, we hope to achieve more volume in MIS procedures and adequately train the up-and-coming residents in the near future. Thank you.
Thank you very much, Dr. Nixon. Our next speaker coming is Dr. Mikhail Higgins. He is a proud Bahamian national and the country's first fellowship-trained and U.S. board-certified interventional radiologist. He completed his specialty and subspecialty medical training at the Hospital of the University of Pennsylvania and the University of Virginia Medical Center, and holds a Master of Public Health degree in Healthcare Administration and Healthcare Policy from Yale University. Prior to his return home in 2023, Dr. Higgins served 5 years as an assistant professor in the Department of Radiology at Boston Medical Center and Boston University School of Medicine. He also served as Director of Medical Student Education for the Department of Radiology, as well as the Program Director for Early Specialization in Interventional Radiology Program at Boston Medical Center. Currently, he serves as chair of the American College of Radiology's Appropriateness Criteria Interventional Radiology 2 Expert Panel. That is a mouthful. And as the chair of the Diversity, Equity, and Inclusion Advancement Coalition for the Society of Interventional Radiology. I must say, Dr. Higgins, reading your bio, I felt extremely proud. Dr. Higgins is the founding president of the medical director of the Bahamas Fibroid and Interventional Clinic, which he established on his return home in 2023. He has been nominated by many, and his awards include Global Semifinalist for the Most Influential Radiology Researcher in 2020, as well as he was inducted into the Boston University's Medical Group Clinical Excellence Society in 2021. And of course, his accolades go on. Without further ado, I welcome Dr. Mikhail Higgins. Okay, I'm sorry I have no knock-knock jokes planned.
Amazing. Thank you so much. So first and foremost, thank you. Always prepared and prepared for this. This is how we live our life, right? So Mikhail Higgins, thank you so much. Oh, I need this as well. You guys can hear me as well? All right. So first and foremost, I really appreciate the opportunity to speak to you. Skills so after January 6th, I wrote DEI policy. When I got that, I can tell the joke again. Okay, first of all right. So what I said was, all right, glitch, perfect, good. Uterine artery embolization, innovations in interventional radiology. So one of the most important things I think about this conversation is that when I trained, when I practiced in Boston for 5 years, my best friends, the people that I really went to bat for were the surgeons, and they went to bat for me because in the middle of the night, when SHIT was hitting the fan, who was in the hospitals? The surgeons and interventionists getting things done. And so that is why really and truly I'm here, to advance the dialogue, to open the lines of communication, so we could get to the point where we are in the hospital battling it out for the benefit of our patients, all right? So the first thing we're gonna talk about is UAE, which is, can this work? Does this work? No. Nope, not working. All right, all done. Oh, okay, so what I'll do is I'll just use it like this, good. Perfect, is that good? So UAE is one of the many procedures that we have in the armamentarium as interventional radiologists. So I have a few goals and objectives for our discussion today. The first is I want you to be able to recall the relevant uterine artery and pelvic vascular anatomy. I know we have some medical students and residents in the room. The second is I want you to understand the indications for UAE through a few clinical cases. This will be a case-based symposium. I want you to be able to cite some procedural steps of UAE. So if you were to come and shadow me, I want you to be able to say this is what Higgins is doing. All right, and I want you to be able to recognize how to distinguish specific complications versus expected post-procedural findings post-UAE. All right, so let's get to work. I know many people in the audience probably don't even know who this is, right? Who is it? Well, I know you know. I can see you look seasoned. All right, but for the unseasoned people in the audience, all right, the people who don't know, about Pinder soda and them kind of thing. This is Mr. Rogers. All right, so Mr. Rogers is a person who back in the day when I was 4 and 5 years old used to take a very difficult concept and used to turn it in such a way where as a 4-year-old I was like, wow, how am I able to understand this and remember this even as an adult now? So what I'm going to do for you is I'm going to take you on a whirlwind. This is going to be a roller coaster. We're going to get through a lot of concepts. It'll be fast, it'll be furious, but I want you to just hold on. So what is interventional radiology? Just sort of start with that. One of my students, I told him I was giving a talk to some surgeons, and they was like, just show the slide. And I was like, you know what? I don't want to end up in accident emergency, so I'm going to show this slide instead. So when you think about IRs are problem solvers. We untie knots. We unpack nuts, okay? So you send us a patient, you know what the problem is, the patient comes back, the problem is solved, but nobody really knows what we do, but this is going to attempt to tell us what we do. So back in 1964, there's an actual shirt that came out, at our symposium a few years ago, Interventional Radiology, Creating Procedures for Other Specialties since 1964. So a little bit of a joke, right? But it's true. Back in 1964, this occurred. So this was a patient by the name of Laura Shaw, and there was a doctor by the name of Dr. Kripanar. He was a general surgeon at Oregon Health Sciences University. So this patient went to him with gangrenous toe ulcers, and Dr. Kripanar, doing what he did as a general surgeon, he said, this needs to be amputated. She said, absolutely not. Her in her early 80s, she said, you will not amputate my foot. And she pushed back and she pushed back. She said, there has to be another way. He said, there's no other way, but you know what? There's this dude, we call him Crazy Charlie. We're going to send you to him. He's probably going to say, no, he can't do anything, and you come right back to me. So what he did, Dr. Daughter, Charles Daughter, the father of interventional radiology, he basically said, you know what? I'm going to get access to your common femoral artery with a needle. I'm going to send a wire down. And he said, you know what, let me inject some contrast. So the contrast went down. This is the superficial femoral artery. This is the femur in the background. And this critical stenosis showed up. So he said, all right, let me get a wire across that. And let me take a dilator and pop that open. He popped it open. He said another bigger dilator over, and he popped it open some more. A bigger dilator, he popped it open to the point where it looked like this. And he said, all right, now we're working with something. He brought the patient back a few weeks later, and this is how it looked. The first example of durable patency in a patient with critical stenosis. So when the patient presented to Dr. Kripanar, this is what her feet look like, right? Gangrenous toe ulcers, clearly why he wanted to amputate these bad boys, right? But this is how the patient essentially healed to 3-4 weeks later, all right? So when it came to Dr. Daughter, the father of interventional radiology, one of his colleagues, Dr. Michael Baird, he said, you know, when it came to being willing to do things and try things, he said it made a lot of people nervous, but it also led to an enormous amount of progress. So when you think about IR, we have rocketed from 1964 to now through innovation, okay? You go back to early 2000s, Dick Cheney was a household name, vice president, and then George W. Bush. He had bilateral popliteal aneurysms. Of course, Dr. Farquharson is the man who treats this now. Of course, when we think about this, Dr. Lucas as well. Now, what we have here is this patient came in with 2 aneurysms. Never before had 2 aneurysms been treated simultaneously. Dr. Brent Brooks at George Washington University and Dr. Harry Caston at Endovascular operated on him and was able to get him back to health. We have Melania Trump a few years back. She had essentially a rupture of an angiomyolipoma. When they get about 4 centimeters in size, they have a natural propensity to rupture. She presented with life-threatening hemorrhage. And who took care of her? Some of my colleagues in Washington, D.C. were able to block up the blood supply to the bleeding AML. Okay. The third person, which is actually one of the people we're going to talk about in our talk today, is Condoleezza Rice. Here it is. This lady came in on a Friday. Jim Spees, one of my colleagues at Georgetown Medical Center, treated her on a Friday, and she was back to the White House on a Monday. People were like, what black magic is this? Is this woman who had fibers treated, and she was back to the White House on a Monday? It made no sense. And the question I always get after when I present this is, patient says, do you treat Democrats? Do you treat independents? All right, but we do. You need not fret. All right, so diagnostic modalities. So this is why we're able to do what we do. All right, we're diagnostic radiologists first. Go through that residency program, painful, it's like watching paint dry. And then they put us in the surgical suites, they put us in the cath lab, they teach us how to manage patients, how to talk to patients, because after being in diagnostic radiology, sometimes you just can't talk to patients anymore, right? And we learn all these skills back, and we're able to use these modalities, the C-arm, the ultrasound, and the CAT scan, do any number of things. Using our basic toolkit, we have a sheath to the left, we have a catheter in the middle, and we have a wire. The catheter acts like our train. The wire acts like our railroad. We send our railroad and our trains follow. That's what we do. And when we're in the body, we're able to do any number of things. So if we're in the blood vessels, we could do bing, bang, boom. We could place a vascular access device, right, like a pore, tunnel dialysis catheter. We could place an IVC filter in order to prevent blood clots from the lower extremities from getting to the lungs. We can perform angiography, a diagnostic technique, injecting contrast and mapping out the inside of vessels. We can place stents to open up blood vessels. We can place balloons in order to open up vessels as well. We can perform an embolization. That could be of the prostate. That could be of the geniculate artery. In the case of knee osteoarthritis, we can perform a thrombectomy. We do thrombectomy in the brain. I do thrombolysis in the lungs, and any number of things in between. We can also cross anatomic compartments. That could be through the skin. So here I am putting a needle on the skin. I'm in a CAT scan, and I'm directly going into a little tiny sub-centimeter nodule in the lung. Here's a case where I'm actually putting a probe, a microwave probe, directly using ultrasound in a patient with the 2.7 centimeter hepatoma. And this patient was able to get pure margin. So instead of having to get surgery, this patient had a little 2 millimeter incision, and he was cured of his hepatoma, his hepatocellular carcinoma. We can do therapeutic drainages, whether it be the abscesses. We can place G-tubes in 10, 12 minutes in a patient using a push or a pull technique. Nephrostomy tubes can be placed directly through the skin in order to decompress the urinary tract, or we can do the same thing for the gallbladder in the case of a cholecystostomy. Right? So, when I was in medical school and subsequent residency, I started hearing about, patients getting hysterectomies. And I was like, whatever, medical school stuff. And then I was like, 80 to 90% of patients have fibroids of African descent. I'm like, this is crazy. And the vast majority of those women get hysterectomies. And so I started reading some more, and I was like, oh, wow, it's not everybody who gets hysterectomies at the same rate in the United States. Women of African descent get offered 3 to 5 times more than their non-black counterparts. So fast forward to me treating patients in Boston who who should be most of the patients that I'm seeing? Women who look like me, right? No, 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 no. They were getting their uteruses removed. However, the women who didn't look like getting treated on a Friday and being back to work on a Thursday. So I decided that, you know what, I'd take a little special interest in this. And so I started looking up and I started reading about Condoleezza Rice. I said, oh, Miss Rice had an embolization. She could have had any procedure she wanted to have, but she chose this. So I said, you know what, let me understand this. So this is what we're going to discuss. The timeline. So when did this first occur? In 1974 in France. In 1974, a patient had intractable menorrhagia, bleeding because of fibroids, was treated by a neuroradiologist at the time. Fast forward to 1995, a gynecologist, Dr. Ravina in France, said, you know what? We're having a lot of issues with complications from hysterectomies and myomectomies, okay? So average time should be 3 to 5 days that the patient's in the hospital for, should be in and out like clockwork. The difference between the Bahamas and France is that it is truly a socialized healthcare system. I know people be like, man, look here, government is paid for procedures here at PMH, but man, it ain't really the same way it is in France. Taxpayers truly pay for it. So if a patient, instead of spending 3 to 5 days in the hospital, on average ends up being 1 in 7 is spending 2 weeks or 3 weeks or a month, taxes will begin to rise. And so they need to crack that nut. So they decided that, you know what, the government said, Dr. Ravina, gynecologist, we need you to figure out how these patients can have less complications, bleeding complications, and end up in the hospital in the projected 3 to 5 days that we've budgeted for. So they got the neuroradiologist at the time. He was an interventional neuroradiologist. He wasn't actually a vascular and a body radiologist. And he said, man, what I could do is surgeons want to operate next week. I operate this week. I embolize the vessels. Next week, surgeons go in. They cut the vessels. Vessels have no blood. They say, all right, sure, makes sense to me. So they did a trial in 1994 to 1995. They started looking at patients, and most of the patients would get the embolization, and the following week, they get the surgery, less complications. Certain patients stop coming in for the surgery. They say, well, did the patients come in for the embolization? They say, yeah, but they didn't come for the surgery. It made no sense. So they started interviewing the patients. The patients said, my symptoms all gone. So, of course, the United States found out about this, being the capitalist society that they are, and they said, we don't just want to save money, we want to make money. So they started offering it directly to patients, and this is when, of course, Condoleezza Rice became the person who sounded the alarm in the African-American community that made it a procedure that they could get. Of course, everybody were doing things that their Grammy and their mummy and everybody had done, but they were able to open up things. And so I started looking at the images, and I said, oh, this is what the fibroid looked like before. This is what the fibroid looked like after an embolization. This is what the fibroid, looked like before. 3 months later, as it continues to regress, it looks like after. And I said, you know what, Higgins, you too shall be able to form an embolization. So at the end of this procedure, my goal is that you too will be able to form an embolization. So the first thing we want to say is, you know what, fibroids are not the only reason why we treat, okay? Perform an embolization. There are bleeds. This is where my surgical colleagues come into play. So the first is anatomic uterine abnormalities. We talk about fibroids. We talk about adenomyosis, which is essentially ectopic endometrial glands that invade different parts of the uterus. Arteriovenous malformations and fistulas. We can be called for postpartum hemorrhages. We can be called for iatrogenic regions like post-hysterectomy bleeds. Or we can have situations where the placenta abnormally implants and then we have bleeding, in which case we have to perform an embolization in that setting. Or bleeding diathesis. I had a patient who is daughter of a VIP who presented and basically had some issues because she had this propensity to bleed. We weren't sure if it was von Willebrand, we weren't sure if it was a factor deficient, but she would bleed like stink. And so we had to perform an embolization on her. So I say, you know what? I say, Dr. Lucas, say, man, you got some medical students and some residents here. And I say, you know what? You know, in Boston and other parts, I would quiz people, but I say, you know what? Again, I don't want to end up in accident emergency, so I ain't gonna quiz y'all. So, all right. So these are parts of the anatomy in terms of the blood vessels that we have to know just in the pelvis in terms of us being able to navigate to and fro, all right? So the most important thing, of course, is the uterine artery. This is the uterine artery. It has an ascending branch that anastomoses with the ovarian artery, and then some descending branches that anastomose with the cervical and the vaginal branches, right? So this is our little territory that we need to be aware of. So how does the pelvic vascular anatomy look in real life? So first and foremost, you know, this is me with a little, what we call tennis racket catheter, omni-flush catheter, okay, at the aortic bifurcation, and sort of mapping things out, right? So taking a little bird's eye view. This is the squiggly uterine arteries that are coming out, and you'll begin to see just a little bit of staining sort of around this region, and this staining is essentially in the region of the uterus, okay? So this is what the anatomy looks like if you were to sort of kind of superimpose the landmarks here. And what we see when we talk about sort of the mapping is we want to know exactly where the catheter tip, because the catheter tip will tell us what it is that we're looking for. All right, so a few cases just to sort of orient us for our purpose of our discussion, right? So here we have case 1. This is 1 hour after delivering a newborn, 40 weeks gestation, vaginal delivery, 34-year-old G1P1 female. She's postpartum, notices that her pads continue to be soaked with fresh blood. All right, that ain't cool. All right, so she complains of feeling dizzy and lightheaded. That ain't cool also. Tachycardia, she's in the 110s. She's hypotensive in the 90s and 60s. Diastolic, hemoglobin is 6. So, based on the weight of the pads, they estimate about 600 mLs of blood loss, right? So the question is how you define postpartum hemorrhage, right? So what is too much? So when we think about postpartum hemorrhage, so first of all, I mean, once you have greater than 500 mLs, you post-vaginal birth or 1,000 after cesarean section, then we got a little bit of problem, right? We got to call Houston, right? Tell them we got a problem. So over 99% of postpartum hemorrhage occurs in 24 hours. So as you move past that 24-hour window, basically the risk for it occurring decreases precipitously. When you think about clinical symptoms, you want to be thinking about obviously the patient if they're hemodynamically unstable, the palpitations, the lightheadedness, the lack of the ability to compensate, the sweating, the tachycardia, the sympathetic response, okay? So when we think about postpartum hemorrhage in terms of different types, there's the primary, there's the secondary. We think about primary, obviously the uterus is not able to contract, right? So it basically just allows sort of seepage of blood. There's iatrogenic causes, which, people don't like to talk about, but they happen. And then retained products of conception, which we'll see an example of, and the bleeding diathesis. Secondary issues would be retained products of conception as well, endometritis, and subinvolution of placental bed, right? Which is one of the reasons why we like to do a DNC after, just to make sure that there's no subinvolution of the placental bed. And then uterine arteriovenous malformations, which are very rare, but uterine fistulas, uterine arteriovenous fistulas are less rare, okay? So when we think about sort of percentage in terms of incidence, by and large, most commonly, you have, uterine atony, right? So uterus is just not contracted appropriately. And so basically you don't have that effective contraction post-delivery. So we want to understand that is obviously something that we can absolutely treat. Trauma is a little different, and it could be a laceration, be an incision. And so the way the etiology of the injury occurs is going to define how we treat it, right? Whether we're using things like particles, whether we're using things like coils, okay? In the case of bleeding diathesis, same thing. Again, a patient could have something like a bleeding diathesis, which could be related to an underlying clotting factor deficiency, or it could be something that is reversible, right? Like uremic-related platelet dysfunction, or the patient could be hypothermic, whatever the situation may be. We want to understand the setting and be able to treat it. So when we think of managing postpartum hemorrhages, there is different levels, as we talked about, based on the amount of blood loss, okay? It could start as simple as, just managing it conservatively, given sort of some sort of uterotonic agent and type in crossing, 1 to 2 units. Or you can get to that sort of 1,000 to 1,500 level range, in which case you say, all right, you know what? You will do the DNC to rule out the retained placenta, and then you will place an intrauterine balloon in order to basically tampen out the bleeding. And then you call me and my friends from IR, in which case it's just me, all right? And then you could transfuse some units. Or you can get to the point where you activate a massive hemorrhage protocol and you call the GYN surgeon, in which case lady may have to unfortunately say bye to her uterus, which is very sad indeed. So when you think about this case continued, in this particular situation, the patient continued to bleed. They gave, a little fundal massage. They gave some oxytocin. They gave the uterotonic agents, okay, and then they did the speculum examination. They didn't really see any lacerations per se, okay, which is a good thing, right? So therefore, they were able to put a DNC because got some laceration. I put the little DNC. People would say, well, you caused the DNC. DNC caused a laceration, so it's good to check before. And the patient continued to bleed, right? So the patient was transfused 2 units. The blood loss at this time was estimated about 1,200 mLs. So then we looked at, obviously, the hemodynamics, and the patient doing a little bit better, but still, obviously, relatively unstable. And so in this case, the intrauterine balloon is then placed, temporarily not to tamponade until IR is then called, right? So this would be an example of sort of when we start thinking about indications for embolization and setting of postpartum hemorrhage. So the patient continues to bleed, what? Despite medical treatment, right? So they're unresponsive, right? Or they're persistently bleeding, and the patient actually had some sort of arterial ligation, which confuses things even more so because now the vessels are obviously ligated incompletely, which is a much harder situation. So we typically like to get the patients up front before our surgical colleagues decide to basically proximally ligate, right? And then, of course, a hysterectomy is a situation where they could go to attempt a treatment, in which case other situations and other issues are caused. What would be some contraindications to UAE? I mean, there's really very little, right? Unless the patient, has some sort of severe anaphylaxis, in which case there are emergent sort of treatments that you can give. And of course you can intubate the patient and you can monitor them and control them. So there's really no contraindications that I've ever come. If a patient needs to be treated, we're going to treat them, okay? So let's talk about UAE and let's go step by step, right? So of course, we want to get permission from the patient. We place a Foley catheter to ensure that obviously the patient know that they can be using the bathroom during the procedure. So we can collect the urine, it's a concierge service. That's just how we roll. So lower extremity pulses, we mark them because we want to make sure that we start the procedure. If it's 2+, we finish the procedure with 2+. We start with 1+, we finish the procedure with 1+. And of course, if the patient's unstable, we don't want to be catching patients as they hitting the ground. So we say, man, look here, Dr. Nemo or Dr. Leach, could you help us out a little bit over here and support this patient and give us some guidance, all right? So when it comes to sort of labs, things that we typically check, we want to check their coagulation status, make sure they're not coagulopathic. We want to make sure that we know exactly, obviously, where the hemoglobin is, right? Is it sort of, dropping precipitously, all right? Of course, in certain situations, the patient could obviously, have other issues that may be going on, in terms of infection and whatnot. BUN is important to know, obviously, as we talked about, uremia-related platelet dysfunction, which can sort of adversely impact coagulation. And then creatinine is something that we just want to be aware of since we're given contrast, okay? And this is a little bit of a procedural overview, all right? So we start the procedure, getting access into the common femoral artery. In my case, some people get into the radial artery. I don't typically like to use the radial artery for a number of reasons. Then we perform our pelvic arteriogram, and then we sort of continue on mapping out the sort of pelvic anatomy. Then we get to a point where we perform the embolization subselectively. And then afterwards, once we accomplish the job, then we get out of Dodge and hold pressure. So this is an example of what we're doing here is I'm getting access to the blood vessel in the right common femoral artery. The next place, once I place the sheath, now we're going to obviously map things out in the pelvic region. And this is obviously the anatomy that we reviewed previously. This is a pigtail catheter, flush catheter, which actually has multiple little sort of kind of holes on it. So it kind of sprays contrast at the appropriate rate. This was invented by one of my former professors, Dr. Cope. And then we have basically an example now where we are sort of in the internal iliac artery. And what we're doing now is we're mapping out uterine arteries, okay? So then we then go, as you say, all right, so we in the uterine artery now, we mapping things out. You see the uterine artery here at the bottom left of the screen, and what we're doing here, bottom right of the screen, sorry, on your end, and we're sort of watching exactly sort of where it's going. We're paying attention to other branches, right? These are actually branches that go to the cervix and the vagina. So if you technically didn't know what you were doing, and I was involved where I was asked to be an expert for a case in New York, where the interventional radiologist actually embolized this, and the lady ended up with a ulcer in her cervix and her vagina, right? So you got to know the anatomy, 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 okay? So here's another example now. So we're in the left uterine artery. We're using a microcatheter. We talked about the wire being the train tracks. We talked about the catheter being the train, but then you have smaller train tracks, which is a microwire, and then you have a smaller train, which is a microcatheter. And so what we're doing is we're performing this coaxially, which is through one catheter, we're putting another catheter, almost like a little telescope, okay? And so one of the things that is the most important sort of decision factor in any embolization is what material are you going to use to block off. We talked about, if you have a situation like a laceration, okay, right? You definitely, in a case of a laceration, you can use a coil because it's a very sort of, circumscribed area that you can flank. If it's something that is like uterotomy, all right, this is all of the uterus that is failing to contract, then you want to use something like particles. The next decision tree is if you want to use something that's permanent or not permanent. You want something that absorbs versus something that wants to stay in the system, right? So this is the kind of things we think about. So gel foam is something that obviously you as surgeons know, right? You know polyurethane, you know about medical grade sponge. This is what we use. It's purified skin gelatin, and this can cause what we call cross-sectional obstruction, okay? And so the whole goal is to sort of cause stasis, so we activate that sort of slowing part of Werkhaus triad, okay? And then one of the pros of this is that it gets reabsorbed, which is great. It starts sort of recanaliting immediately after place. And then the second issue, what we sort of think about is that sometimes it could be so temporary and to just make sure you get a certain level of stasis. And this is sort of where the art of embolization kind of comes into play, okay? This is an example, I'm doing a little demo for some of my residents, showing them how to make sort of a gel foam slurry, and I'm sort of making it sort of in sort of this little crosshatch pattern, and then I put it in, and I have 2 10 ml syringes, and then I'm mixing it with contrast, certain dilution of contrast, to get to the point where it actually looks like a slurry. And this is basically the way the slurry looks prior to essentially embolizing, okay? So this is an example of once we get started. Now we have obviously the slurry in place and we're ready to perform the embolization. And this is post-embolization. You see sort of this sort of kind of static column. It basically sort of static column, whereas here, it's basically kind of going out. It's a little difficult to see because the lights are on. And then here, this is sort of the back and forth, which basically shows that the pressure head is basically being balanced because we've reached the therapeutic endpoint and achieved stasis, okay? So now, once you get to the other side, so the person who embolized Condoleezza Rice, Dr. Spies, he famously goes in both groins. He goes in the right groin to get to the left side, left groin to get to the right side, okay? So Dr. Spies has been around for a while, and he was probably not around when Dr. Waltman, Arthur Waltman, who was a interventionist at Massachusetts General Hospital, created what we call the Waltman technique, which is basically where you can do a technique that allows your catheter to form in such a way where you take a hairpin loop and you can bring it back on itself and you can use it. So we are able to use that. And then Ann Roberts, who's a mentor of mine at UC San Diego, created a catheter because she trained at MGH. She created a catheter that does this on its own, right? So you don't have to use the special technique in order to form the Waltman loop. But here I am for the purposes of the residents, showing them how you could form the Waltman loop using the Roberts uterine catheter here. And this is the little tiny train, which is the microcatheter at this particular point. So that's the microcatheter directly in the uterine artery. And this particular patient had a specifically large and well-developed uterine artery, okay? Once the sheath is removed, of course, I tell people, it's like, no matter how well you fly the plane, if you can't land the plane, come from around here, all right? Because, listen, you got to land the plane, right? You could have the best flight, from Paris to New York, and man, you eating your chocolates on the plane and thing, and man, if that pilot start doing some little something, you about to land in JFK, ain't nothing happening, right? You ain't going on a flight again, right? So you need to know how to not only sort of do the procedure, but you need to be able to know how to achieve hemostasis. One way is, of course, you think about the blood sort of moving from the heart, right? So down to the legs. So, of course, we want to make sure that most of the pressure is above, obviously, the dermatotomy, the skin site. And you also want to know that dermatotomy, where the skin incision is not the same site where essentially the hole in the artery is, right? So you need to know exactly where that is based on your particular point. So typically 2 fingers above and 1 finger below in order to slow it down after the incision, okay? So this is something else that's used depending on the scenario. And of course, Dr. Farquharson, he's the master of these type of things. I'm not sure if he's a Perclose guy, but I would imagine that he is. These are different things. This uses a metal clip. This uses a collagen plug. This is an example of a collagen plug and angioseal. This is a suture-based closure device that typically closes and sort of cinches the vessel almost like a toggle. And then there are ones that basically placed on the inside of the vessel, and there are ones that placed on the outside of the vessel in terms of closure, like something like Minx or Exoseal is one of these things that typically use. Post-procedure management, obviously you want to make sure that the patient keeps their legs nice and still. You want to check the patient's groin, pulse checks, things of that nature. So case 1 continues. So hemostasis achieved, post-anesthesia recovery. Now 4 hours later, the patient had some spotting on the vaginal pad, right? So the first thing is, people always ask this question, right? So Higgins, man, my bleeding stop, man, but I want to have more children. So this thing ain't gonna affect my chances of having no children, eh? So then the mic gotta drop, right? So the first thing is that there are multiple retrospective studies have shown that there's no significant effect on fertility, menses, or pregnancy outcomes post-UA, right? So let's run through a few studies. So first of all, more recently, the Radiological Society of North America published this article where there was about 359 women who were unable to conceive, right? And then they had spontaneous pregnancies. So of the 359, 149 of the women were able to get spontaneous pregnant, okay? This line shows the spontaneous pregnancies, and this line shows the ones that brought them to term, okay? So very close to the amount that was able to essentially get pregnant, we were able to bring them to term. But beyond that, understand that there was crowding in the uterus, and these women couldn't get pregnant to begin with, all right? So it restored fertility in those cases. The other situation is that you have this study where they looked at a number of 42 patients underwent UAE for various uterine pathologies, whether it's fibroids or AVMs or things of that nature. And what they found is that they excluded patients over the age of 35. So this is focused on young patients now. People say, man, Higgins, man, you don't treat young patients. Like, man, I treat them all. All, big, small, I treat them all. All right, cool. I don't discriminate. DEI, I tell y'all, I into DEI, man. All right, so this left 28 patients with an age range of 22 to 35. 14% of them underwent UA to treat the AVMs. 43% had postpartum hemorrhage, and the remaining 43% had fibroids. So that was the disease sort of kind of, range in terms of what was being treated. So 24 of the 28 patients had at least one successful pregnancy. That was 86 of them, okay? 86% of them, and 21% of those patients had two successful pregnancies. The majority of women, 2/3 of them were able to have a normal vaginal delivery, okay? Now, the other point was that what was the average time for that first pregnancy? It was about 15 months, okay? Now, this is probably one of the more important sort of studies by Dr. Vogelsang from Northwestern, where they did a systematic review of the literature. And basically, the party line was that there was some low-level evidence that suggested that pregnancy rates following UA are comparable to age-adjusted rates in the general population, right? So as you get older and you get close to the average age of menopause, which is 51.5, your pregnancy rate is going to decrease every single year. That's just fact. If you compare you to the same population of women, 39, 40, 41, 42, that get UAE, there's no significant difference between those groups, okay? The other piece is that when you think about sort of, uterine artery embolization, what we're doing is we are actually reducing the burden of disease that actually may be preventing you from actually conceiving or having the 40% complications that women who have fibroids have, whether it be preterm labor, whether it be mandatory cesarean section, whether it be abruption of the placenta, or whether it be issues of breech position or miscarriages, okay? So these are just things to sort of keep in mind that I always try to make sure that I tell patients, and which is what I told this theoretical patient here. So, one of the things that we want to talk about is complications, and we want to think about other indications for UA, right? So we'll just talk about this for a bit, right? So 29-year-old patient, history of varicose veins and anemia. She's presented ED with 4 days of vaginal bleeding associated with lightheadedness and visual changes. So she stated that since yesterday, she's had profuse, bright red bleeding with big blood clots, okay? She states that this is unlike her usual menstrual bleeding, which started 4 days ago. And then we have a blood pressure, which is normal. Heart rate is 151 beats per minute, so a little tachycardic. Hemoglobin is 6.7. By a little, I mean a lot, all right? And so when it comes to sort of thinking about common and uncommon causes of abnormal uterine bleeding, people talk about endometrial malignancies. This is like 3% of the population, but we just don't miss it, right? And the things that I think about when I think about endometrial sort of dysplasia and hyperplasia is patients that have essentially menstrual menorrhagia that occurs for 10 days or more, patients that have intermenstrual bleeding, or patients that have sort of repetition of their cycle 20 days or less. Those patients deserve an endometrial biopsy, okay? Of course, when we think about fibroids, it's 20 to 80% depending on whether they're Asian or whether they are women of African descent. And we think about those are the structural reasons we talked about before, and these are non-structural regions that can cause, obviously, the bleeding from the uterus, okay? So this patient had some iron infusions, had some fluids, some tranexamic acid. They were transfused 6 units, PRBCs over 3 days, and then the conservative measures just didn't work. So they did an ultrasound. So on this ultrasound, what you're going to see is a little something just keep appearing like right here, right? So what that is what? That is basically a little scar, right? Calcification at a prior cesarean section site, okay? But there's no fibroids, right? So let's delve into this a little bit more. Right? So patient says, man, look here, doc, man, I don't know how to cesarean section, man, but I won't get pregnant again. So I was consulted to determine the source of uterine bleed and possible intervention. So I say, all right, man, let's just follow this yellow brick road, man, see what's going on. So we keep going, and in this case, get left radial artery access, because would stay from that groin. And so I come down and I get access, and what you see, man, when you get away from the heart, the vessels should get smaller. They shouldn't get bigger. So when you going down, and then the big boy come up. So you come down, you see this little squiggly boy, and then big boy come up again. I say, oh, something here right here. So what is this? Basically what this is the following. This is the uterine artery coming here, okay? This is an arteriovenous malformation. This is a nidus, so a tangle of vessels. This is the early venous filling, early draining vein. And this is basically now getting ready to show us that this don't belong in this poor woman, right? So this is now an example of an embolization for an AVM. And what is the difference between an AVM and a normal vessel? So typically we know that obviously the veins, venules, capillaries, arterioles, artery, that should be sort of the normal sort of kind of transition. But in the case of a nidus, basically everything all tangled up. You always see this sort of nidus of vessels, okay? And then you see sort of in an early draining vein is sort of one of the most common sort of telltale signs. In the case of AVMs, they're congenital. That means that you're born with them. In the case of AVFs, they're acquired. And they can be acquired from any number of things. And one of the most common things is a DNC, okay? Now, when you talk about prevalence and complications, AVMs represent about 0.1% of women. And they typically present with sort of abnormal vaginal splitting. And then, or they can range from spotting to hemorrhage, right? And the hemorrhage is very scary when it occurs. Now, they can also present with other things like, examples of increased venous pressure, and one of which may be vulvar varices, and you have like a little sort of dilated veins on their labia majora or minora, and then you say, oh, something ain't going on. And then you can have sort of dilated varicosities in their thighs as well. And then, of course, the complications are the following: the life-threatening vaginal bleeding, and then how output cardiac failure as the heart continues to work and work and work because it's not getting the accurate, efficient blood flow around the circulatory system. Okay, so when we think about sort of alcohol and gel foam, these are two things that I would use in this case to destroy a nidus. So what I'm doing here is I am demonstrating the nidus, and this is after I've injected a combination of gel foam and alcohol to essentially dissolve these vessels that really shouldn't be in place. Okay, so that's the post-embolization. So again, pre-embolization, what you see here is the nidus, okay, and this is the post-embolization appearance, right? Now, one-day discharge, the patient now presents with pelvic pain and cramping, nausea, vomiting. And so what are some possible causes of these symptoms? So this is where we talk about complications. And I just like transparency just for transparency purposes. That's how I just roll, you see. So when it comes to sort of the early complications, we talk about pain. Usually my patients, after a week, 7 days, the pain sort of continues to de-escalate. And then they may have issues like they pass sort of pieces of tissue. So depending on the location of the fibroids, they may pass pieces of tissue. That's all normal, but we cause some complications because we just want people to be able to explain what's happening. New hot flashes and night sweats. The post-embolization syndrome occurs, and one of those aspects of the syndrome is actually having a low-grade fever. Okay, infection is something that should never occur, right? So we just want to understand what that means. And then persistent bleeding is something, again, that can occur in 2% of cases, right? So very, very unlikely for us not to be able to treat what we need to treat. Now, when it comes to sort of, discharge, the discharge can be sort of a watery discharge. It could be sort of little sort of dry pencil eraser, and that just has to do with the location of the fibroids. After 8 weeks, about 16% would stop, and then about 1 in 5 cases, you can have a little discharge beyond 2 months. Now, one of the things that people talk about, post-embolization is the fibroid ischemic pain, which basically is one of the reasons why women who have fibroids have sort of, cramping to a degree that is really disproportionate to even the size of the fibroids. Is because fibroids harvest prostaglandins. They concentrate them. So when they die, it's almost like taking baby powder and opening it up. So it just basically fills the blood system in that region, and it causes a lot of cramping. So that's one of the things that we treat, and it dissipates usually within the first 24 hours. So the first 24 hours, I tell my patients, man, it's like a hurricane. And then after that, it basically is completely gone, okay? But post-embolization, which is where you can have the low-grade fever, you can have a leukocytosis. These are all things that occur in that first week. So if a patient came in and I didn't give her anticipatory guidance, say, man, you have some pain, maybe up until, 4 days later, but don't be alarmed, all right? If she goes to the hospital and you do a CBC on her, you may see 15 to 30,000. You say, boy, something ain't right. But that's all normal, okay, which is important for you guys to know. Now, fibroid expulsion is something that we call a complication, but it basically has to do with the location of the fibroid. So if you have a little tiny fibroid that's this is the endometrial canal, and greater than 0.55 of it is abutting that surface, it could essentially slough off, okay? And if it sloughs off, you may see it, right? So this is an example of a patient who had a myomectomy, and it was incomplete, right? So the patient, they asked me to do the procedure. We do the procedure, right? And unfortunately, okay, 2 days, the patient became toxic. So unfortunately, this fibroid had been in the vault for a while. It had been detached from the attachment to the endometrial wall, and so it became necrotic. And because the patient didn't have a pregnancy before, it didn't pass. And so because it didn't pass, it became necrotic, and unfortunately, they had to do what? They had to do a hysterectomy, which is very, very unusual, right? So patients opt for hysterectomies, but this is an unusual situation where we would say, all right, you know what, this would be a setting where we would do it. But again, incomplete myomectomy, so we had to come in. So it's important to know all these things. So we study complications, even the rare ones. So expulsion is something that we always think about as well. This is a patient of mine who came in with this big old bad boy, and then about 4 to 6 weeks later, expelled it, the whole thing, right? So that's just how it rolled sometimes, right? So in the case of this patient, this is an example of patient who, if you can see here, this is the endometrial canal. Okay, this is the fibroid. You can see this is not greater than 0.55, but this is almost like ready to come out, and so this was able to slough off as well as like a whole, which is unusual. So a few questions here. So a patient with chief complaint of menorrhagia undergoes successful UAE, presents to the ED following evening with intense 8 out of 10 non-radiating pain, diffuse cramping, mild fever, vaginal discharge, some vomiting, and the patient has a white count of 15,000. So what's your name? Sorry? Chana. Chana, man, this question is for you, man, Chana. C, post-embolization, because that's, man, Chana's a smart gal, man. I just want y'all to know, man, trust me. So although most patients have pain after UA, true post-embolization syndrome affects 5 to 10% of patients. Patients typically present with chief complaint of severe abdominal pain. Associated symptoms include low-grade fever, nausea, vomiting, and of course, taking up the leukocytosis to 15 to 30,000, okay? So this question is for you. What's your name, sweetheart? Glendira. Glendira, man, look here. 45-year-old female. Is for, before I start the question, I gotta say, look here, right? So 4 months post-UAE, complains of new vaginal discharge without debris, significant cramps or fever. So what is the most likely diagnosis? Yeah, man, that's how you go. That's how you go, you see? Yeah, man, I had faith in you, man, all along. All right, so fibroid expulsion has been described as a bulk sort of discharge where a large piece of fibroid may pass vaginally, resulting in cramps and possible fever. So sloughing expulsion usually does not have any pain or fever. It has to be managed effectively. So you can do hysteroscopy when possible to accelerate the passage, or it can just resolve on its own. Okay? So that's something to know. So, I come into you. I come into you, man. You ain't my friend over here, man. I gotta make sure y'all redeem because this, she doesn't have it unlocked, man. What's your name? Anaja. All right. What complication is more often seen in a 51-year-old woman as opposed to a 44-year-old woman following UAE? Trust me, man, you gotta knock this one out the park. Rah! All right, boom. So this is how we roll, right? So first of all, in a multi-center prospective single-arm clinical trial, 538 women, okay? 8 patients experienced amenorrhea 3 months after UAE, okay? So why is that the case? So a sharp increase from 9 to 41% of patients experience amenorrhea when comparing 8 subgroups, 45 to 49 and 50 or older. But the problem is that this is just an age-related phenomenon. True and unrelated, man. You know what I mean? They was on their part to menopause anyway, man. If you want to try to blame me, man, I can call my old lady, man. You know what I mean? So that's just how it goes. So let's review what we covered. So first of all, I want you to recall the relevant uterine artery and pelvic vascular anatomy. I think y'all got that. I want you to know the indication of UAE through clinical cases. I think we done beat that horse dead. And I want you to be able to cite some minor procedural steps of UAE. I have faith in you. And I want you to be able to recognize how to distinguish specific complications versus expected post-procedural findings. So we were able to accomplish that. So just a couple slides here. Other indications of UAE. These 4. So first of all, IUD. You've been uterine device. Sometimes people just remove IUDs and it just don't go right, man. And I mean, I support IUDs for the purpose of IUDs, but sometimes, man, when they come out, they just fight you when they coming out, right? In this case, it's fought this woman, right? She ended up with a perforation, right? So, man, what we had to do is that ain't cool. What we had to do, you got me, sir? All right, there we go. What we had to do is we had to go in and block her blood supply, but unfortunately, she had the hemoperitoneum as well, and then, unfortunately, they decided they wanted to do hysterectomy in her particular case, even though we were able to stop the bleeding, okay? Here's the case, post-hysterectomy bleed. You have the abdominal hysterectomy. So, all right, cool, thank you. So 29-year-old female status post C-section, abdominal hysterectomy, so persistent hematocrit drop, concerns for bleeding. Here you see a little hyperdense and active contrast-extravasation in that region. So we said, man, look here, bring this patient and let us embolize her, man. Right, so what you see here is actually just what we call hyperemia, so pooling of contrast, right? So we did all the things we would normally do, and then we did a gel foam embolization, right? And everything was hunky-dory in the world, right? So in this particular case, this is a little bit more complicated. So this is gestational trophoblastic disease versus a uterine AVM, right? So what we're looking for is we're looking for tiny little vessels, and we're looking for a vessel that goes into what we call the myometrium. So if you think about the uterus as a parachute, right? Hot air balloon. Inner layer is the endometrium. Then you have the junctional zone, which is the intermediate zone, and then you have the myometrium, which is basically where the muscles are, and then you have the skin, which is the serosa. So if you have any vessels that go from the endometrium, which basically sloughs up in the form of period every month, okay, naturally. But deep to that, if you have any vessels connecting from the muscle into the endometrial canal, it's a problem. That means that something either was born there, and then they came out in the case of an AVM, or somebody put some tool like a curettage in, and it pushed directly into the vessel, and it created a iatrogenic injury that now connected the artery with the vein. Okay, so what we're trying to figure is what that is. A gestational trophoblastic disease is essentially trophoblast cells, which really should make the placenta, and they decide that they want to just get real friendly and form a tumor. That tumor could be a an invasive mole, it could be a benign cancer, or it could be essentially a benign tumor, it could be an invasive cancer. Okay, so this is an example of what we're doing here, is trying to map this out here using the ultrasound. So what you see here is what? Now we're getting into other techniques. This is an MRI using specific sequences, and one of the things we're looking at is the following. So we want to see if there's any feeding vessels, okay, into this region. I could tell y'all that there ain't no feeding vessels there, and y'all just could believe me, right? You believe me, right? Man, you look at me, you believe me, man. I ain't gonna test you, you know, 'cause I just, once you say you believe me, man, we friends, man, you know what I mean? So the question is now, you know, early filling of the draining vein versus retained products of conception. Retained products of conception is basically that little tangle of vessels just directly in the endometrial canal, okay? And we're looking to see whether or not, again, tangle of vessels and then a vein or some sort of vessel, artery or vein connecting to the muscle, right? And that's not the case here. So what we see, we make a decision. There's no tortuous feeding vessels. There's no pseudoaneurysms. There's no early venous return. There's no extravasation. So we just say, man, look here, we just do a little gel foam slurry and block up the blood supply. And we say this is retained products of conception. And that's exactly what it was. However, if it was trophoblastic disease, this is what it would look like. It would look like this, and the vessel would go directly into the myometrium, right? This is it right here as well, okay? So you could see, right, this white part is the endometrial canal, and this whole thing is the trophoblastic disease. It's going from all the way here, all the way in here, okay? And this is an example of the vessels here, which again, we had to treat early draining vein as well. So this is how we distinguish these things. And then finally, UFE. I started with UFE, I can finish with UFE, right? So 45-year-old female presenting with bulk symptoms for UFE. These are discrete fibroids that we're looking at. And in this particular case, question is, what does it look like, obviously, when treating the patient? So I'm getting in with the microcatheter. We see the sort of staining in the fibroids, okay? And after that, I block up the blood supply with what we call calibrated microspheres, which is designed for this purpose. And then we no longer see those fibroids, okay? And this is an example of some of the calibrated microspheres that we use. Now, as I mentioned before, when we treat these patients, we see the regression. In this particular case, one of the things that kept this patient up, waking up multiple times in the middle of the night, was what? Having to urinate. She would drink a glass, she gotta go. She drank a glass, she gotta go. 3 months later, could she drink more glasses? She drank a little bit more glasses. 6 months later, 9 months later, boy, she said, man, doc, man, I can drink whatever I want before I go to sleep, and I ain't gotta wake up no more. You imagine going to sleep for 6 hours, and every 30 minutes you're up? Don't make no sense, right? Ain't nobody got time for that, right? So this is the kind of thing that we see. In the case of this lady, man, this lady say, doc, what you mean by how many times I use the bathroom per day? I only go once a week, right? Why is this? This fibroid is pressing on her what? This black thing is her rectum, right? You can't see the rectum pass here because that fibroid say, man, look here. You know, stomp out, man. So what you see now is as the fibroid begins to sort of shrink and scar down, it's like basically an egg that has obviously, you know, yolk in it. And this is an empty egg now. So now as stool begins to pass down and the movement occurs, it pushes that scarred, obviously, fibroid down. And this lady was able to help. She got me and say, man, doc, man, ask me the question again. I said, what question? How many bowel movements I have a day? I say, how many bowel movements you have a day? Doc, twice a day. Every time I eat, I poop. So this is what we look for. This is what we look for. So we want to see that regression over time. And these are a few testimonials. And again, you know, I start and finish in the same way by thanking Dr. Lucas, because, you know, when I came back to the Bahamas, one of the things that really, really troubled me was the fact that, you know, again, being in the U.S., I had so many women who didn't look like me who obviously get in this embolization procedure. And I asked myself, well, why is it that women who don't look like me feel like it's not for them? And I said, you know what? I don't need to figure that out up there. I can figure that out down here, right? Because obviously being able to come back home, we deserve exactly what Condoleezza Rice chose for herself, as being the best thing for her advisors, for her to choose for herself. And so I said to myself, you know what, if I'm going to offer things like stroke care, if I'm going to offer things like pulmonary embolism care, if I'm going to offer things with my boy, Dr. Farquharson and Dr. Lucas for critical limb ischemia care, or place tips for patients who have, refractory variceal bleeding, if I'm going to get to the point where I offer all these procedures, I can start with what I feel is the greatest epidemic in the Bahamas at this particular time, which is obviously fibroids. So thank you, Dr. Lucas, for allowing me to speak to you today, and I hope that this is the beginning of many conversations. So thank you, and God bless. Yeah, all right, so I appreciate that. Thank you so much, Dr. Menace. So first and foremost, great quick question. So back in the early 2000s, nobody wanted to treat what they call megafibroids, so 10 centimeters or older, because the thought was just that this infarction would be to the point whereby it would just, I don't know, a patient would blow up or something, right? They just was like, I ain't gonna do it, right? But then they realized that they're able to treat these patients, and these patients were able to regress. That example that you saw in the patient initially where it actually sloughed was a megafibroid. That was like 13 centimeters, okay? That whole thing sloughed. I mean, 13 centimeters, that's what that was. That sloughed, okay? Now, there are other times where you saw an example of the patient where it was pressing on the bladder, and that actually regressed and shrunk, right? So these things happen, so it shrinks. My patients always ask me, they say, what happens to the tissue, right? So I didn't start off by saying this, but what is a fibroid? A fibroid is a benign muscular tumor, right? What's your name, brother? Donovan. Just jack a pose for me for a second. Just do it, jack a pose for me for a second. All right, John. All right, man, look at Donovan. Donovan got guns, man. You know what I mean? He got guns, man, right? So that bicep that Donovan have, if I was to take his bicep and I was to put it in your uterus, it would basically hijack the blood supply, right? And that's basically what a fibroid is, okay? Now, if Donovan, I ain't gonna say this, I can just knock on wood. If something was to happen to Donovan and Donovan ended up in the hospital for a month, what would happen to his guns? They shrink, but where they can go, they can come out his belly button, you can puke them out, they can come out his nose, where they going, where they can go? You say nowhere? You always say nowhere, man. Try again on that one, man. I gotta give you another chance on that one. Where they can go? Where's muscles gonna go? You could say it. They could just get absorbed, right? They can get absorbed, right? And so the same when you in the gym and you lifting, you taking protein, you taking carbohydrates, and you taking fat, macros in a specific ratio, and that ratio is designed for you to build muscle. If you can't do that in the hospital, again, the first law is energy is neither created nor destroyed, right? So if the energy was able to create that, what will now happen? During the time of distress, that energy, in the same way if you have an ice cube, it will melt, and if you collect that water for your benefit, you'll be able to use that water. So during a time of distress, your muscles will begin to atrophy and think. When we embolize and cause infarction, that begins to get absorbed. So what we know now is if you control and you have appropriate embolization, you can actually have an appropriate infarction and absorption of the tumor. That's number one. In terms of pedunculated fibroids, my mentor, Schlansky Goldberg, who was the first person to demonstrate expulsion and document expulsion of fibroids at Penn, he treats all pedunculated fibroids. Okay, I'm not going to say I'm risk averse. However, what I decided is when I came back to the Bahamas, I said I was going to do certain types of cases initially, and then once I get a certain threshold, okay, 500 cases, okay, then I'll move into certain. So I basically told Lon Charles, okay, who was my boy, I said, Lon, I said, every pedunculated fibroid that comes to me, I will give to you, right? Because I don't want to know that if I treat 100, there's going to be one patient that basically, two things, okay, one patient versus two patients. Two patients who don't get an effective embolization. Reason being is because if, depending on the size of the stalk, you can block off the stalk before you basically block off the fibroids. So you have fibroids that are still living and a stalk that is basically partially infarcted. So the fibroid patient still having symptoms, and I've just basically burned the bridge partially, okay? So I said I didn't want a poor result from patients more often than not. And number two, I didn't want to get to the point where the stalk necrosed and then the necrotic fibroid basically dropped in the abdomen. So I said, bro, this is a fibroid where you could just go in, and this fibroid basically trying to jump out the body, man. I say, man, it's an easy one for you, man. This is like Pippen giving Jordan the ball, man. You know what I mean? You just got to dunk it, right? So he say, man, Higgins, man. All right. So I give him. Those are the patients that I basically referred to him. So that has been my MO, is any patient that's pedunculated, I basically tell them, I said, I treat every fibroid except a specific type. And unless they're that patient, they don't know what that type is. And when they get, it's basically been probably 3 patients or 4 patients over the past 3 years that I've basically referred, and those are the patients that get the myomectomy. And those are good laparoscopic cases, depending on the size of the fibroids as well, right? I like to make people look good, man. You know what I mean? Because I make you look good, you make me look good, man. You know what I mean?
When you take your referrals, do you insist that you have a endometrial biopsy sampling?
No. So my criteria, and I probably gloss over this because I was moving pretty quickly, was if a patient has a period that lasts 10 days or more, if a patient has a menstrual cycle that's 20 days or less, or the patient has actual intermenstrual bleeding, not spotting a few days after period, but rather period stops, okay, on day 5, and then 5 days, 6 days, 10 days later, they have cherry red gush. Those are the 3 criteria I use to perform an endometrial biopsy. Next question is, how many patients on average I send for an endometrial biopsy? In the Bahamas right now, I would say probably 1 in 9 patients, right? For every 9 patients I see, one of them meets one of those criteria, and I pass it on to, typically, Nina Graham is the one who does all my endometrial biopsies. Dr. Charles is the one who treats all my patients who may have other things. So that's sort of the, I don't want to use the term alliance because that's a charge word around here, right? That's the crew. You understand? So that's the crew, right? Yeah. Great question, Dr. Menes. Sorry.
A question regarding your recommendation or how you approach nulliparous women who have intracavitary fibroids.
I don't treat them. That's another group, right? I don't treat intracavitary fibroids. I didn't show the study here because it's a whole different talk. Is intracavitary fibroids, those are depending on the size, right? So as the size increases, you have to use more saline, okay? And you can get to a point where if you have not essentially pre-embolized, you could use a certain amount of saline that could actually result in an epilepsy, okay? All right, because of hyponatremia-induced epilepsy. So it's actually in your best interest, depending on a certain size of intracavitary fibroids, to work with interventionalists. And that's when I'm working with my GYN, my MFM, maternal fetal medicine colleagues, my MIGs, my minimally invasive gynecologic surgical. Those are the patients that we collaborate on, right? Gets a certain point, 4 centimeters and greater, we will basically go ahead and do the case together. I'll pre-embolize, and within 48 hours later, they'll go ahead and they'll go and do the procedure because they have to use less saline because there's obviously less bleeding. Mm-hmm. So those are slam dunks for them, right? So that's how we operate on those. I don't deal with intracavitary fibroids, period, because again, I want the patient of the best outcome, and that's what the data says, is that the best outcome comes when you pre-embolize.
So thank you very much, Dr. Higgins.
Absolutely.
So the answer to that question is you have to have some kind of what we call intracavitary morcellation devices. Unfortunately, at this time, we have none in the Bahamas. That's the answer. We had it one at the doctor's hospital, which they didn't keep a track of it. So it's an upper version. It's a TrueClear. So the newer version of TrueClear is available in market, which doctor's hospital don't want to buy. You can't really think about that in Princess Margaret Hospital. There's a new one like a MyoShear, and there's other one also, Symphion. But that is the answer. That is because whenever you talk about intracavitary fibroid, depending upon what size and how speedily you could do, because how Dr. Higgins has explained, intravasation of saline hyponatremia can cause death also. Mm-hmm. And trust me, that has happened already in the Bahamas. So the two ways you could handle is, one is the morcellating devices, and second is resectoscope. Resectoscope is a skill, and you could do that also. Depending upon the size, you may have to prepare your patient for multiple sittings. You may not be able to take that out in one sitting, but there are 2 options. So resectoscope is available in the Bahamas, but the morcellation, which look really, really nice because it's fast. It has its own suction and it has its own fluid monitoring system, so it is safer that way. We still trying to get that. Yeah, that's the short answer.
Great. Thank you so much. Yeah. Great. Thank you so much for the opportunity. Really appreciate it.
And I think I'm inviting Dr. Lucas. Okay, so refreshments time.
So, please be reminded, after the refreshments, we'll have our skills lab wide open. So please take advantage. Thank you so much for coming. Thank you, everyone.
And see you tomorrow at 8 a.m. right here.